happy that I'm today with you. I'm sorry that I'm not directly this time the assessment of insulin. Dear colleagues, I'm very happy that I'm today with you. I'm sorry that I'm not directly physically in Cairo, but I would like to thank my dear friend Inas Shaltut for this kind invitation, and I hope that I will be with you in some future meetings, of course. So today I would like to talk with you on the clinical implications of insulin resistance and prediabetes. This condition is a complex issue, and we can talk about the insulin resistance that is leading into the prediabetes and diabetes mellitus at the end. So we have, at the beginning, the reduced sensitivity of cells to insulin, then we have elevated blood glucose, and finally, we had chronically elevated blood glucose that is unable to produce, actually related to the body's inability to produce enough insulins. If we want to make a definition of insulin resistance, we can say that this is the metabolic condition that is combining different things, including the body's tissues like the skeletal muscle, liver, and the adipose tissue. But of course, there are lots of outcomes that are related to insulin resistance, and presumably it is the type 2 diabetes, polycystic ovarian syndrome, inflammation of the liver, dyslipidemia, cirrhosis, etc. So we have lots of things that are related to the existence of insulin resistance in the post-insulin resistance period. If we are looking on the timeline of the key discoveries in our understanding of insulin resistance, we can see that above the red line we have the discoveries, and below the red line we have actually the therapeutic approach, and they are following each other. Firstly, the discoveries were in the early 20th century, in 1922, when actually the first patients received the insulin injections for the treatment of diabetes, and it was rapidly and constantly moving into the current period, and this enlargement of activities starting in, let's say, 1980s or 1990s, when we have actually, for the first time, the assessment of insulin resistance, the pathophysiology of type 2 diabetes, and the discovery or the production of the first therapies that are related to insulin resistance, meaning that we start to treat the pathophysiological mechanisms. If we want to take a look on the therapeutic side, we can see that the NPH insulins firstly started, and then in 40s, and then later on we had the oral compounds that were developed and very rapidly developed in the recent period up to now, and we have lots of new drugs in the pipelines with the combination of the new incretins that are coming steadily to the scene with the different therapeutic possibilities, including type 2 diabetes, but also obesity as the precondition for diabetes. If we are looking on the events and the years, we can say that in the first, let's say, half of the 20th century, we had some timelines that were related to the discovery or understanding of the carbohydrate influence on blood sugar levels. So we could say that there are direct effects on the nutrition, on the levels of the blood sugar, and then the first tests that were introduced and conducted as the first test was the 100 grams of the let's say glucose tolerance testing. In 60s started the rationalization, rationalism started to be present, so we start to use, for instance, the 1 hour sampling in the tests, and that was recommended. And in late 60s, at the beginning of 70s, we realized that insulin resistance is the core of the problem, and then the definition or the diagnosis of insulin resistance started, and the HOMA index was discovered as the very simplified index, I can say surrogate index for the definition of insulin resistance or the insulin sensitivity. In 80s, it was first classification of diabetes based on 5-time point of GFP, In the late 80s, we had the discovery of insulin resistance syndrome by Gerald Reaven, and then we had the first clinical trial, famous DCCT, and especially UKPDS study, meaning that the first therapeutic approach was applied, and that was metformin at the time. And recently, we were celebrating actually many years of introduction of metformin in these studies, lasting for more than 40 years. So we have broad experience in, let's say, the cardiovascular outcomes, and this is it's not a new discovery. It is something that was recognized many years ago. So in 2010s, we were actually including some very simple biochemical marker, which was the HbA1c testing for the diagnosis of diabetes. So it is a large scale of activities from the diagnostics actually to the therapies and the following of the therapeutic outcomes in this period. If we are talking of the diagnostic methods, we can start from the clamp. So we had the hyperinsulinemic euglycemic clamping, that is the gold standard for measuring insulin sensitivity by at the same time infusion of insulin and glucose to maintain normal blood glucose. And this is the direct measurement of whole body glucose disposal with a high accuracy under the very controlled and strict conditions. And that's why this test could be performed only in the hospital settings. That's why it is quite expensive, labor intensive, and time consuming. And that's why we nowadays start to use more simplified tests. But in the history of the assessment, or let's say trying to recognize or realize what is the insulin resistance, we start to use the OGTT, but this test is actually the test for the diagnostics of diabetes or impaired glucose tolerance, and it involves just ingestion of the 75 grams of glucose and the 2 hours plasma glucose level determination in the diagnosis. Actually, this test is today tried to be used as for the assessment of insulin sensitivity by using the basal glucose and insulin, but this was not a very useful tool, and we deliver from that, we actually derive the simple HOMA test or the HOMA index from this whole testing. The next test could be the continuous infusion of glucose with the model assessment or the sigma test, which evaluates insulin sensitivity using steady-state glucose and insulin levels after continuous glucose infusion. So this is cheaper and less invasive than clamp, and it also reflects peripheral insulin sensitivity. This means that we start to have more specified tests, and with some specifically precluded conditions, we can separate from the, for instance, the assessment of central to the peripheral insulin sensitivity. One of the attempts to use more computerized methods or the computerized formulas, it was the minimal model test analysis or the minimal model testing, which was developed by Bergman and Cobelli in 1979, that provides an indirect measure of insulin sensitivity by using glucose and insulin data obtained during the frequently sampled intravenous glucose tolerance test. This is a useful test for the assessment of insulin sensitivity and glucose effectiveness during few hours of the assessment, but this has limitations, especially in individuals with impaired insulin secretion or significant insulin resistance, where it may overestimate glucose effectiveness and generate non-systemic errors for the assessment of insulin sensitivity. That's why we are using those surrogate indexes, and one of the most famous are the HOMA index, which actually measure the risk of insulin resistance level. So everything which is below 2 could be assessed as the insulin sensitive condition, with a normal actually insulin sensitivity around 1, and if we have over 2 and especially over 3, we can say that this person or this subject is with a very high insulin resistance. That's why in this attempt to find the best predictor of insulin sensitivity or estimator, we came to the non-insulin derived indexes, and one of the newer ones is the single point insulin sensitivity estimator, or the SPICE index, which is the non-insulin derived index with a better accuracy than the other indicators in the prediction of metabolic syndrome. This formula is using the HDL cholesterol, triglycerides, and the body mass index. With this calculation, we can actually see the SPICE in SPICY with this condition. And in one of our recent papers, we analyzed a group of women with polycystic ovarian syndrome. We found that in the controls, the SPICE index was actually 8.8, and with the most resistant level with the phenotype B, which is presumed to be the most potent endocrine or the hormonally affected condition with women with PCOS. So phenotype B is the real endocrine profile, and we can say that the SPICY index is actually marking this condition quite nicely. On the below part of the slide, you can see that the HOMA index is actually the opposite. It has the highest index with the phenotype B, and this relation, this opposite relation, is actually confirming that the SPICE could be used as the simple and non-insulin related index. Then we are coming to the insulin resistance conditions and where they could be found. So the polycystic ovarian syndrome, type 2 diabetes, obesity, or the metabolic syndrome are the conditions that are hallmarks of the insulin resistance today. If we are talking about the polycystic ovarian syndrome, this is the most prevalent endocrine metabolic disorder, affecting about 10% of reproductive age women worldwide using the NIH criteria from 1990. This percent is coming to over 20% if we are using the Rotterdam criteria from 2003. So the features are including the hyperandrogenism, either biochemical or clinical, ovulatory dysfunction, and polycystic ovarian morphology. Insulin resistance and compensatory hyperinsulinemia are considered major drives of PCOS pathophysiology and are involved in the development of hyperandrogenism. That's why on the right-hand side of the slide, you can see the combinations. So if we have phenotypes A and B, which are including the most potent endocrine features like hyperandrogenism and the anovulation, we can say that about 80% of those are with the insulin resistance. On the other side, the phenotype C, which is the hyperandrogenism with the polycystic morphology, is less, let's say, affected by insulin resistance. And the lowest one is the phenotype D, which is actually showing connection between the structure of the morphology and the anovulation or ovulatory dysfunction. What about the pathophysiology? Insulin resistance is including in the pathophysiology of polycystic ovarian syndrome. We have the condition of this hyperandrogenic state. We have actually decreased insulin receptor binding, and then we have the hyperinsulinemia, which is affecting the liver and the ovary. With the ovary, we have excessive androgen production, and with the liver, we have decrease of the SHBG, and then as the net effect, we have free androgens that are in circulation, affecting actually the body of the woman. There is some genetics or the genes that are involved in insulin resistance. Today, we considered mostly involved insulin receptor gene, and we also the PPR gamma. Both of them are affecting the insulin sensitivity. The PPR gamma is quite interesting and not so much present today, the activity over these receptors, because we have the actually effect of adipocyte differentiation, lipids, and glucose metabolism that could be used as the therapeutic tool or the therapeutic direction in these women. But because of the lack of the quality drugs or combinations, we do not have much more results in this area, and I will talk about that at the last slide. What about the aging? During the life, the glucose levels are increasing. So during the life, we have increase of glucose in the decades of life, and this is constantly present. Then we have insulins also that are fluctuating but steadily and constantly increasing during aging, and also the HOMA. So the HOMA index is increasing and showing that we have the condition of insulin resistance during the aging. If we put into the combination body mass index and the aging, we can say that women during aging are deteriorating their insulin sensitivity, but we can say that during analyzed quartiles of this group of women, if we especially analyze the older and younger age and their body composition condition, we can say that women with aging are deteriorating insulin sensitivity, but if they are remaining more lean, they can remain with the previous level of insulin resistance. They will not change their insulin resistance into the let's say non-optimistic way. Then we can say that they will not develop actually diabetes. So aging is a process of definite condition, but if we have differences in the body composition and especially with the levels of obesity, we can actually increase our way or our pathway toward the diabetes. This way to the diabetes is very sure, and this study, which was the analysis of the long-lasting or the long-standing follow-up from the Italian group, from Bologna, that were following those women for over 1 decade, showed that the increase of the baseline fasting glucose of only 10 milligrams per deciliter can increase 50% hazard ratio to develop diabetes. So very direct and very obvious consequences. If we take a look on our data from the very old paper, we can see that everything which was present there actually was repeated later on. And we can notice that the insulin sensitivity was decreased with the PCOs. We can see that the HOMA index is quite much higher than with the controls. But if we also take a look into the lipids and the lipid indexes, we can see that the triglycerides start to be elevated, HDL decreased, but more importantly, the oxidation of LDL is an important condition or the important marker with the PCOs, meaning that they are prone to develop atherosclerosis and they are considered to be the pro-atherogenic condition. So we have actually the pro-atherogenic risk factors quite nicely defined in these women. Therefore, the manifestations of PCOS at different ages are really varying from the exaggerated adrenarche in the peripubertal period to the polycystic ovarian syndrome in adolescent and adulthood period toward the metabolic syndrome with aging, which is characterized by dysglycemia, hypertension, dyslipidemia, and obesity, leading toward the cardiometabolic conditions. So we are starting from reproductive ones and then coming to the late cardiometabolic consequences with the diabetes, which is the most possible to be developed later in life. What is in the core of the problem? These are the adipocytes. So we have aberrant morphology of adipocytes. We have larger adipocytes. We have lower serum adiponectin levels. We have increase of the insulin resistance and inflammation. And with the markers, again, I'm talking about lots about markers. So we have quite nicely defining markers with the PCO. So we have increased the TNF-alpha, interleukin-6, leading toward the macrophages involvement and the quite defined inflammatory condition. Pathophysiology is even more complex. We can say that there is the fetal programming and the effect of stress and the change of behavior toward the increase of appetite, but then we have also very important role of the cortisol. So we have the increased activity of the HPA axis, and then we have the metabolic syndrome in the core of the problem. We have insulin resistance together with the oxidation. We have the possibility to expect dyslipidemia and type 2 diabetes, and all of those are leading toward the cardiovascular condition. In our recent papers, let's say one of the biggest studies that we jointly undertake with the colleagues in Greece, we found that our patients using the National Cholesterol Education Panel, Adult Treatment Panel number 3, show that we have significantly high percentage of metabolic syndrome with PCOS in comparison to controls. And we show clear difference. We can compare this to the other parts of the world, but this is not very easy to compare because we have the situation in South Asia. There are some results from Sri Lanka that showed that the metabolic syndrome is quite pronounced toward the going up to 30% in comparison to 6.3% in the controls. So we could not say that we are such in a high problem, but clearly we showed that the women with PCOS, even in Europe, are affected and could develop the metabolic syndrome. Obesity, as I said before, is in the core of the problem. We have huge, big adipocytes with the increase of the inflammation or inflammatory factors. We have the leptin resistance and free fatty acids that are leading to insulin resistance to the peripheral tissues or the liver. And we have the apoptosis, which is, again, leading toward the glucose production and glucose uptake diminishing, and then we have actually diminishing of insulin secretion. This is leading toward the impaired glucose tolerance and diabetes at the end. Our recent analysis of the data from the PubMed or the Central and of Scopus databases in 2020 showed that there is a relative risk of 3.1 time to develop diabetes in women with polycystic ovarian syndrome. So we have clear demonstration that in the different ovarian studies, we have quite clear association between PCOS and type 2 diabetes. And then we came to the new things, that is the cardiovascular kidney metabolic syndrome. So the insulin resistance is even evolving into the, let's say, new kid on the block, which is the complex metabolic syndrome, which is now including not only the cardiovascular outcomes, but also the kidneys, starting from the increase of the lipid accumulation product that is combining waist circumference with plasma triglycerides. We have the, which is the marker of abdominal adiposity and associated with cardiac morbidity and mortality. In the heart, we have the relaxation, which is impeded by epicardial adiposity or the adipose tissue. Then we have the cardiac myocyte apoptosis that is promoted by saturated palmitic acid. That's why the palmitic acid is under the restriction of use and is suggested not to be used in the everyday life. And then we have also the heart failure that is also associated with ceramide sphingolipids, and then we have the hypertrophy of the left ventricle that is also related to the lipid accumulation product. With the kidneys, we have proximal tubal resorption of fuels and electrolytes, which is impaired by ceramide sphingolipids. Again, the problem of the metabolism of lipids, and also the